Thank you, sir.
So, Dr. Veena is also a consultant pediatric endocrinologist at the Anantapuri Hospital. I'm here from Pune, but I'm introducing actually a local speaker from Trivandrum. Over to you, doctor.
Sir, I'm also an SGPG alumni, so glad to meet you. Thank you, and my sincere thanks for the organizers for having given me this platform. So today we'll be seeing something about insulin pumps. The automated insulin is a device. So my role here as an opening batsman is to tell how insulin pumps are useful in diabetes. So in the initial years, in my practice, I was also apprehensive for recommending pumps to my patients, thinking that it was only a device which will reduce the number of pricks. But what pumps do more than reducing number of pricks in getting a better glycemic control and improving the quality of life, we'll see in the next few slides. We know that managing diabetes is like walking over a tightrope, with all those glucose excursions, highs and lows, having acute complications as well as long-term complications. Diabetes mellitus be type 1 or type 2 has got some form of insulin deficiency. In type 1 we know that it is an absolute insulin deficiency, mandating insulin therapy lifelong using the latest recommended regimen of multiple daily doses or basal bolus therapy. And type 2 diabetes is basically a relative insulin deficiency, and at some point of time patients do require insulin treatment for better glycemic control. And we know that the only effective insulin delivery route is a subcutaneous plane, be it using syringes, the good old syringes which nowadays very few uses, or the pens, different types of insulins and insulin pens. And technology has given us a boon of painless insulin delivery system in the form of pumps, which we are now going to learn about the various advantages of this delivery system. So if we take the subcutaneous injection techniques, the recommended regimen is intensive insulin therapy, which requires minimum of 4 injections per day. That is the 3 pre-meal short-acting insulin boluses as well as once daily or twice daily, depending upon which insulin we use for the basal insulin requirements. So if we take minimum 4 injections per day, the child or the patient who is following the intensive insulin regimen should be receiving at least 1,460 shots only for survival. This does not include those extra injections taken for corrective doses or those pricks the child has to suffer for getting therapy, particularly in the pediatric population as well as in the adults. So let us go for the basics of insulin secretion and let's see how these pumps do a better job than subcutaneous injection regimens. This is the picture showing the normal, natural glucose secretion pattern, glucose levels in the body during the meals as well as in between the meals. And then the down purple, you have it. Okay, the purple one is the insulin secretory pattern, and we can see that there are the body needs glucose continuously, as we know that all our body cells, glucose is a fuel for functioning. So this is the post-meal excursions in the glucose levels, and we have in between the basal glucose secretion. And you can see sometimes the insulin secretions, we have post-meal bolus secretions followed, and there are intermittent basal insulin secretions. That is, the body is continuously producing insulin at a particular rate so that the cells can utilize the hepatic glucose produced in between the meals. As well as it will help to, the bolus insulins will help to deal with the post-meal glucose excursions as well as store the glucose in the liver. So if you closely monitor the insulin secretory pattern, you can see that the basal insulin secretion is not uniform. It has also variabilities. It is in different ratios it is being secreted. There is at times it is low, at times it is high, not along with the meals, not associated with the meals. Otherwise also at some times body requires more insulin and sometimes body requires less of insulin. So it is not a uniform business which is happening in terms of natural insulin secretion. And this is what we are actually trying to mimic. The intensive insulin therapy tries to mimic the pancreatic insulin secretion. So to mimic what we do, we give a basal once daily or twice daily. The peakless insulin needs to be given only once daily so as to mimic the basal insulin secretion by the pancreas, and we give pre-meal boluses using the rapid acting or the regular insulins in order to cover the post-meal glucose excursions. So we think that this is mimicking the normal physiology and will help us to get a better glycemic control. But if you overlap these two, see background, this is the body is on natural insulin secretion, and then you have the black one is the basal injection we are giving, and the blue ones are the pre-meal ball shots. So if you can see, there are so many lacunae between the natural secretion as well as the treatment injections. You see, we know that in the natural insulin secretion it is secreted in two phases. There is a first phase, rapid bolus secretion, depending upon the carbohydrate content of the food, and that is by the already formed insulin being secreted into the system. And then you have the slow release, second phase insulin secretion. So it is not that easy and that simple as we think. So here there is this is not being taken care of by the subcutaneous bolus injection. If we take care of this, then they will have subsequent hypoglycemias. So basically the intensive insulin regimen does not exactly match the body's insulin secretory mechanism. So here night time you can see here body has got lesser overnight, especially in children, they do require lesser insulins at night. But when we give once daily basal insulin, they will have already higher insulin in the system. That means once you inject the insulin, it is already there in the system. We cannot adjust the insulin subsequently. The basal insulin rate cannot be adjusted subsequently. It will act, it is guaranteed. So that is the problem with intensive insulin regimen cannot exactly mimic the body's insulin secretory process. So these are already discussed. These are the areas where we cannot exactly match the secretory pattern. So what insulin pump does? Pump, is a subcutaneous continuous insulin delivery infusion device. It is the closest mimicker of a pancreatic insulin secretion, and what does is it allows the user to control exactly the amount of insulin delivered by changing the settings as per the daily diurnal variations or diurnal requirements of each person. Likewise, the pre-meal bolus, the rate of delivery of the insulin and the speed of delivery, how much proportion has to be delivered over how much time, everything can be pre-planned and pre-programmed in an insulin pump, just like the body does. And the increments can be as low as 0.01 to 0.05 units, but as against the pen devices where we can only give 0.5 to 0.1 unit increment, decrease or increase in the insulin doses, which is very difficult in young children. They might require even lesser increments for 0.25, 0.1 units, which is very difficult to give in case of syringes or pens. And we can have variable basal rates. I have seen the previous graph. The basal rate itself is got a great variability over the 24 hours time. So that depending upon the basal requirements, the basal rates can be adjusted. Even 48 different rates can be set pre-programmed in a pump device. That will make life more easy and simple for the patient. So it's a computerized battery operated pump allows the user to control the amount of insulin delivered. It has a pump reservoir that holds the insulin dose. Usually for every 3 days we have to change the reservoir and the subcutaneous cannula. So the amount of insulin required for 3 days will be taken into the reservoir and it will be kept inside the pump machine. And there is a thin plastic tube you can see, which is coming from the pump to the subcutaneous cannula, which continuously pushes insulin into the subcutaneous plane depending upon the rates we set for basal, and then we can deliver the bolus doses just before the meals. So this is how the pump delivers the insulin. The basal rates can be different depending upon the requirements or the patient's insulin requirements and the activities or something like that. And then we have the bolus insulin. That bolus dose can be calculated based on the bolus wizard calculator, which is incorporated in the pump. That will be discussed later. So why pumps provide better control? Because in the pump, in our intensive insulin regimen, we use two different types of insulins, the basal insulin or the peak length insulin, and the short-acting or rapid-acting insulin for the meal boluses. The pump uses only a single type of insulin, that is a rapid-acting insulin, for both the basal functioning as well as the bolus functioning. It minimizes the insulin variability. It delivers insulin in two forms that I already said, the basal one, by releasing small amounts of preset at a preset rate, which replaces the long-acting insulin we are giving in the intensive insulin regimen. And this small amount of basal insulin covers the hepatic glucose production and maintains the glycemic stability in the fasting state, that is between the meals and the overnight time. It automatically delivers precisely programmed doses, and it adjusted to match the diurnal variations of that particular patient. The bolus doses is the same insulin contained in the pump covers the bolus doses, and it covers the food intake and corrects the high blood glucose levels. And already said it has got a bolus wizard calculator, which if we put the amount of the carb count the carb in the food we are going to eat, and put the carb counts and the blood sugars in pumps which are already augmented with sensor or clubbed with sensors, the pump will have the current glucose value, and we are putting the carb counts, and then the pump can calculate the correction dose for that particular meal, taking into account how much insulin is already there in the system from the previous bolus and the basal rate. So it will give a value which we can take with confidence to cover that particular meal bolus. And as I said, the basal insulin doses can be modified into multiple rates within the 24-hour period. So here in this one you can see that in children particularly, they have reduced insulin requirements during the evenings and the overnight, and increased requirements during early mornings and after dinner. And some children will have excessive dawn phenomenon, early morning hyperglycemia, particularly in the adolescent phases because of the hormonal changes. And in such cases, we can actually adjust the pump basal, like multiple basal rates have been programmed in this particular graph. Like that, we can every half an hour, every 1 hour, we can adjust the insulin basal rate can be programmed. Like that, 4 different programs can be set for a week. For example, in the weekdays they'll have a particular schedule, and weekends they'll have a particular schedule. They'll be going for any sports activities. So like that, we can previously itself we can program these basal rates. And such hence insulin pharmacokinetics can be closely matched to the individual requirements. And moreover, pump can be switched off whenever needed, if it is needed. But in subcutaneous insulin injection therapies, once given, we cannot switch off the insulin action. It will go continuously. So, but in pump, that is one of the main advantages. Particularly those who are having frequent severe hypos, that cases we can switch off the pump, or in some other occasions we can switch off the pump. So what are the advantages of insulin pump over multiple dose injections? It definitely improves the glycemic control. It reduces the frequency and severity of hypoglycemias. Particularly the newer pumps, they have threshold suspend or predictive suspend, because the pump can sense whether the glucose is decreasing, and that time it can start reducing the insulin delivery even minutes or hours before actual hypoglycemia happens, and prevents the occurrence of hypoglycemias. And there will be reduced glycemic variability, which is a very important marker of glycemic control. Definitely in those having a higher HbA1c, after initiating pump, the HbA1c will definitely come down. But those who are having a near normal HbA1c, there will not see an HbA1c improvement, but we will see improvement in the time in range. That is the percentage of glucose values which are in the set normal target range. That is the better indicator of glycemic control than HbA1c, which is just an average of the blood sugars. And thus it will provide an improved quality of life. And let us see what research gives evidence about the advantages of pumps. So the studies show that the episodes of severe hypoglycemia has been reduced in those pump users compared to multiple daily injections, and there is definitely an HbA1c reduction in those who have a higher A1C to start with. They showed significant reduction in the HbA1c. This is one slide which shows that HbA1c is not a good indicator for glycemic control. We can see these are 3 patients' CGMS recordings. All 3 of them has got A1c of 7, but we know that this person has the best glycemic control because all his sugars are in the target range. But this first person has got only 40% in the target ranges. He has got extremes of values, so many hypos and so many hypos, so the average comes to normal, and we falsely think that the patient has got better glycemic control in terms of the HbA1c. But in the pumps, the target range, the number of percentages values in target range will be increased, so that way it will improve the glycemic control. And regarding the long-term complications, the study has shown that there are 45% reduction in the fatal coronary heart disease, as well as 27% decrease in the all-cause mortality rate in pump users compared to multiple daily injection users. And we have so many different types of pumps available in the market, starting from the early manual pumps to, just like the mobile phones or the smartphones or the vehicles getting updated every second. The pumps are being updated in order to suit, the daily requirements of patient. We can just forget about diabetes, I think, with the latest pumps. So the latest in that addition to the pump group is the advanced hybrid loop pump, where the basal rate, we need not set the basal rate. The pump itself will set the basal rate according to the set target blood glucose levels using a magical algorithm, which Dr. Veena will be speaking to you in the next few slides. I'm not going to details. And this is just a summary of this automated insulin delivery. The pump automatically gives the basal insulin doses, and even bolus, even though in the current pumps we need to deliver the bolus doses, even if it is insufficient or is in excess, over the next few hours the pump will automatically adjust, brings the blood glucose level within the normal level, preventing hypos or hypers using micro bolus technique, again based on the algorithm. So all these pumps are currently available in India for use. And which all group of patients are benefited from pump? One, patients with recurrent decay or hospitalizations, even with MDI, those who are having severe glucose variability, and those whose insulin requirements are very little, especially children, and it is very difficult to titrate the doses using syringe or pen, just like less than 0.5 increments we cannot do with pen or syringes. And those patients who are unable to self-administer insulin or eat at exact timings to maintain the glucose level up to hypoglycemia, like preschool children or toddlers. Then in conditions where tight control of glucose is required, like in professional sports, pregnancy, or in presence of micro or macrovascular complications, we can recommend pump is a very good choice. Selection of right user is the key to success of pump therapy. So the indications that those patients who are unable to achieve a target of less than 8.5% HbA1c with the basal bolus regimen, and those who are having frequent hypos, either nocturnal or physical activity induced hypos, those having severe non-phenomenon like early morning hyperglycemia is very difficult to control with insulins, basal insulins. We can recommend pump which will improve the quality of life, especially, and also the patients who are willing affording and willing to take pump, it will definitely improve the quality of life. In conclusion, insulin pump therapy represents a more physiological way, closest mimicker of the natural physiology of insulin secretion than MDI. It improves the survival and quality of life in type 1 diabetes patients and other diabetic patients. It definitely reduces episodes of hypoglycemia and improves the quality of life. Thank you so much for patience.
Thank you, Doctor.